Hello, my dear friend. A very warm welcome to all of you in this NEET PG PSM recall session. The first question, which was quite new, was from Colombo Plan, and they ask what it is focused on, whether it provide PET scan or capacity building or provide chemotherapy or cobalt therapy unit. So this Colombo Plan started in 1950. And it has Australia, Canada, Japan, New Zealand, UK, USA, the member of it. And it opened AIMS also by taking fund from New Zealand. But the main plan is that it can offer advice on local problem, train local people, and Canada is supplying cobalt therapy unit to medical institution under Colombo Plan. So answer was provide cobalt therapy unit, although capacity building is also a work of Colombo Plan, but cobalt therapy unit from Canada was the direct answer for this question of Colombo Plan. Okay. The next question was from the concept of potential year of life lost is calculated as. So this is again a direct question from Park. They have discussed this, that year of potential life loss simply means how many years you lost due to premature death. Let's say, suppose the life expectancy is 75 years and someone died at 35 years. So 75 minus 35, that means 40 years will be his potential year of life lost. Okay. So this is different from DALI. When we read DALI, DALI has the concept of two things: year of life lost due to early death plus year of life lived with disability. And DALI is the best morbidity indicator. So we use it to get fund for hemiparesis patient and mental ill patients. Now there is one more thing known as Sullivan index, which is a bit confusing and from the same part. It simply means life expectancy minus DALI. Okay. So let's take an example, a story to understand all these three concepts separately. Let's say an Indian died at 62 years and this Indian lived his last 10 years with hemiparesis. Died at 62 years and last 10 years with hemiparesis. So if the life expectancy of Indian is, let's say, 68 years, then how many potential year of life he lost? 68 minus 62. He lost 6 years of life which he could have lived. What is the DALI in this case? Year of life lost plus year lived with disability. So he lost 6 years and he lived 10 years with hemiparesis. So total DALI will be 16 years. Now, what is the Sullivan index for this person? As I said, Sullivan index is life expectancy minus DALI. So life expectancy here is 68 years and DALI is 16, which we calculated above. So that means Sullivan index will come out 52 years. And Sullivan index tells us how many years a person has lived without disability. So in this story also you can understand that till 52 years, this person had no disability. After 52 years, he had hemiparesis. So Sullivan index tells us year of life lived without disability. Okay, this is the story of my own father. He lived till 62 years and last 10 years since my second year of MBBS, he had hemiparesis of left side. He died 4 years back, and every parent from the core of the heart, they just want your happiness. They ask you to give good score in entrance exam and all because they think that you will be more happy if you clear your entrance exam. You will be happy for the rest of your life. So they pressurize you. But try to see the inner feeling of your parent. They only want you to see happy. So whatever you are doing, try to enjoy the journey. That's their main purpose. And remember, these three indicators are totally different. I hope this story will make you realize all the three things separately. Now, the third question was a question based on a female who presented at PHC with ultrasound report that she is 6 weeks pregnant and her hemoglobin is 9. So what is correct for iron supplementation in this female? Should we give iron between 8 to 10 weeks? We give iron for 180 days under Anemia Mukt Bharat program, whose target is to reduce anemia each year by 3%. So under Anemia Mukt Bharat program, we give 180 days of iron tablet, 60 milligram iron and 500 microgram folic acid per day. So it means these two suggestion that 8 to 10 week, 10 to 12 week is never correct, because they are saying to give iron tablet only for 2 weeks. Now, give iron after 20 week will not be correct, because then it will not be 6 months. 6 months is after first trimester. There are 6 months in which we have to give iron folic acid. So we read in our textbook and practically we start giving iron tablet after 12 week. But if we are calculating it from last menstrual period, then first 14 days she cannot be pregnant. She must have ovulation occur at around 14 days mid of the menstrual cycle, and from there she carry on the pregnancy. So that means we can calculate her 12 plus 2, 14 week from there, from last menstrual period, give iron after 14 week since last menstrual period. That will be the correct answer. And in the option they had not given that since last menstrual period, but we can write 12 week as 14 week if we are calculating it from last menstrual period. Okay, we can take 14 week as the most correct answer here. Now, this was an interesting and very confusing question, that how will you collect bacteriological sample of water for bacteriological survey? And in PARC it is written that to collect the sample you have to be precise like a surgeon. The main confusion was among option C and option A. In option A they have written collect water coming in stream to avoid splashing of water. That was the complete option. To avoid splashing of water, we have to take it from the stream. And then the C option say that it should be taken after 1 minute. Why B and D can never be correct? Because if you put tube close to tap, then you will take the bacteria of the tap also in the sample of water. And if you collect water dribbling from tap, then you will again collect some more algae and other sample usually present around the tap, or you can take the bacteria of the tap in the sample. So these two we can never do. Now A and C, what is correct? So for that we have to go into the PARC and see it. If you look at the part of collection of sample from a tap, they have said that the water run waste at least for 2 minutes, not 1 minute. That is 2 minutes we have to wait in order to flush it, the interior of the nozzle, and to discharge the stagnant water in the service pipe. Okay. So we should not collect it from the tap just after 1 minute. We should collect it after 2 minutes. Now in the next line, if you see, the sample bottle should be filled with a gentle stream of water from the tap, avoiding splashing. This part is correctly written in the option, and they have used the same word, that it should be a gentle stream. Even the gentle word was in the option, and avoid splashing. This complete option was there. So when I saw this question first time, I answered it as this 1 minute as correct. But the PARC has clearly written that 1 minute is wrong. It should be 2 minutes. And the correct answer is A. Collect water coming in stream to avoid splashing of water. That is a correct way of collecting sample water from tap. Okay. So the answer was A, not C. Okay. Now, the next was this question that there is a group of workers in aniline dye industry who are seen to have urinary bladder cancer. Then they did a study where they took the past work record, and based on past work record, they came to know that workers have more cancer than office people. So this is an example of retrospective cohort. Retrospective and historical cohort are the same type of study in which we take no personal history but past work record to compare. We can take past work record to compare, or we can take past written data. Okay, written data or work record to compare. Now, there is one more type of cohort which is known as mixed cohort or ambispecative cohort or nested case control. So, what is this? Let's say you did very well in your exams and then you took radiology and you are giving a big party, and a neighbor living close to you, suppose his name is Majnu, he came to you and said, hey, why are you doing party? Don't you know that radiology staff have 1.1 more risk of developing Tata's cancer, testicular cancer, as compared to staff of other department, and it is based on 10 year of work record data. So he's talking about retrospective cohort. Now what will you do? Because 1.1 risk is very small risk. And let's say if 6 people develop cancer in radiology, 5 in other, even then the risk will come 1.2. So this is negligible risk. So what you can do is, when you take your MD as radiology, you can start a study in which for 3 years you will follow the radiology staff and compare it with other staff, and along with future 3-year follow-up, you can also use past 10-year work record data. So in this case, you are going in both direction, 3-year future, past 10-year. That will be mixed cohort, ambispecative or nested case control. Now, out of 3-year future follow-up and 10-year past data, which one is more difficult to collect? Of course, future 3-year follow-up is difficult. Past data can be collected on the same day by click of one computer. And main work is 3-year of cohort. And in that 3-year of cohort, we are inserting the data of past. Cohort में केस कंट्रोल का डेटा घुसा दिया गया है. कोहॉर्ट में केस कंट्रोल ने घोंसला बना लिया है ना. इन द कोहॉर्ट डेटा ऑफ केस कंट्रोल इज नेस्टेड, inserted. That's why it is nested case control. So now, how will you remember these 5 names? Very simple mnemonic is RH positive man. Because we all know in erythroblastosis fetalis, man should be RH positive, woman should be RH negative, only then it happen. R stand for retrospective cohort, H for historical, and mixed, ambispecative and nested case control can be remembered by man. So you can remember these 2 separately, where we only take past written record, and these 3 separately where we take past and future record both. Remember, in both type of study, outcome, exposure, both are present. Outcome present, exposure present. Because when we do normal cohort, in normal cohort, like prospective cohort which we say, in prospective cohort, the exposure is present, but outcome is absent. Okay, here exposure, outcome both are present. That is one main difference between these 2 cohort and prospective cohort. Okay. Now, next question was that blood pressure of a group of people were collected at a younger age, and later it was found that participant with more blood pressure at younger age also have more blood pressure at their older age. So this is the concept of tracking phenomena. If we are taking BP of some people, let's say at 10 year, 20, 30, 40, 50, 60, 70, 80, 90. So if suppose one child have BP like this, second child have BP like this, third child have BP like this. So the child with BP more at 10 year will also have more BP at 80 year. It's like BP is tracking that boy. This is known as tracking phenomena, which is being given here. Okay. Kaplan-Meier survival plot is used to compare that which surgery is better, which has more survival. Suppose you want to compare between angioplasty and stent, or you want to compare between unilateral and bilateral knee transplant. In that case, we draw Kaplan-Meier survival plot, which looks something like this. Like, these are the years of survivals by 2 different intervention. Okay. Let's say this one is stent and this one is angioplasty. So this one will be Kaplan-Meier plot, and this is tracking phenomena, which was given here. Now, next question was again a concept mixed with opthal, that there was history of low vision at night and dryness of eye in a mother who had not taken papaya, mango and other fruit, because villagers think and say, and even city people think and say, that papaya especially can be abortifacient. So they don't take it. And like my wife has also not taken it, papaya, because my mother was insisting on it. So in that case, who will visit their home and detect for vitamin deficiency symptom? Will it be ASA or will it be Anganwadi worker? Because ANM is at sub-center. She had no role in visiting the houses. She sit at sub-center, do ANC visit. Sometimes she can visit village for vaccination program at Anganwadi, but she does not check for these things in female. Trained birth attendant is mostly in those areas where home delivery is high, like tribal areas, and she also have no role in home visit. Anganwadi worker has role in giving supplementary nutritions to the mother, and this is not her work to visit and search for such cases in pregnant female. Whereas ASA has been given this work that she will do the ANC, she will motivate the mother for ANC checkup and vaccination, and she will do home visit also. Okay, after pregnancy, she does home-based postnatal care, and before pregnancy, she visit the home during ANC period to notice any complaint, and then she report to ANM about those complaints which is there. So ASA has this work of visiting the house and reporting such cases. Now, when I was taking this review session on Alan only, this was my introductory slide. And in my introductory slide, I told that this one question is going to come for sure in NEET exam, that what is the difference between RDA and estimated average requirement. And actually in exam it came. The difference is that recommended dietary allowance tell the dietary need of 97.5% of population, whereas estimated average requirement tell the dietary need of only 50% of population. That means RDA is always bigger than estimated average requirement. RDA is for 97.5% healthy population. Estimated average requirement is for 50% of healthy population. Okay, so what was the question? The question was average dietary requirement needed to fulfill demand of 97.5% of healthy population is known as. Of course, it was RDA. Now, let's look at the definition of all of these four terms which is given in the PARC. RDA, as I said, fulfill the need of 97 to 98% healthy individual. Then there was one option of adequate intake. Adequate intake means what are you taking, what are the healthy people are taking, and if we cannot use RDA, then we can use adequate intake. So RDA and adequate intake are roughly the same thing, but we use RDA because it is more precise and defined that it is for 97.5% population. Then there was tolerable upper intake level. Tolerable upper intake level is up that amount of calorie which poses no risk of adverse effect for all the people in the population. So that means tolerable upper limit will be more than RDA, because it is the maximum which they can tolerate. Then, as you can see, in estimated average requirement, the average daily requirement to meet the requirement of half of the healthy population, 50% of the healthy population is estimated average requirement. So this is the four term, and I hope you will use it to answer the question of future also. Okay, chalo. Now, the next question was, they gave that there is a people with spasticity around hip joint, they walk with short jerky step, they have muscular stiffness, and they have a history of consuming some local pulses. So what is the poison responsible for it? Actually, there were two questions from neuroletharism. One was this question. Of course, you understand the spasticity around hip joint. This is the first sign of neuroletharism. And actually, the first sign which is there is this, that when they are put under pressure, then their step becomes speedy gait. And I will tell you the line from the PARC itself. And in neuroletharism, which occurred due to taking Khesari Saag, the poison is boa. Sanguarine is the poison for epidemic dropsy, which occur by eating mustard oil contaminated with seeds of Argemone mexicana. And epidemic dropsy have the symptoms of pitting edema on both leg. And then it can go to congestive heart failure. Aflatoxin is found in contaminated groundnut and maize, which is contaminated with Aspergillus flavus fungus, green color fungus, groundnut and maize, and it lead to hepatocellular carcinoma. Pyrazolidine is present in endemic ascites, and this pyrazolidine is present in causes endemic ascites, and it is present in crotalaria plant. This crotalaria mix with Panicum miliare. Panicum miliare, they usually people of rural area, tribal area, they consume. Sometimes crotalaria seeds, which is known as junjunia, mix in Panicum miliare and cause this endemic ascites. So the main confusion which we occur is pyrazolidine and sanguarine. This is confusing. So S for sleeping, S for sanguarine. Okay, and whenever you sleep, first thing is you will not sleep probably, but if you sleep, there is definitely dropping of eyelid, and the symptom is also pitting edema. Dropping going inside, pitting going inside. So sleeping, S for sleeping, S for dropping and going inside. So sanguarine will be for dropsy and pyrazolidine will be for endemic ascites. Okay, I hope the confusion will not be there. Now, what was the second question? In the second question, they gave the symptoms very much similar to the first one. Spasticity along, and they gave this line: crossed lower leg and walking on toes. This is typically the first stage of neuroletharism, where they take one stick to walk, and they have given it in the question also. They use a stick for walking. So this is the second stage of neuroletharism. Now the question was, which of the following will help the villagers? And on first time, I also thought that vitamin B supplementation will help because it is neurotoxicity. So I was thinking about that cyanocobalamin, vitamin B12 and all will be good. But if you go to Park will clear it out that in neuroletharism, the treatment is vitamin C prophylaxis by 500 to 1000 milligram of ascorbic acid for a week. And the other way of helping neuroletharism is by steeping method and parboiling. What is the steeping method? Steeping method means for 2 hours, we will keep that khesari saag in boiling water. This is steeping method being written here, steeping method. Okay. And what is parboiling? Parboiling means we will put this khesari saag in lime water overnight. So this will remove the boa toxin which is there in khesari saag. And you can see the symptoms which are given here. They have given the symptoms typically that first of all, there is a latent stage. In latent stage, they on physical stress, there is ungainly gait. Then there is no stick stage where there is short jerky step. Then there is one stick stage, the second stage, where patient walk cross gait with a tendency to walk on toes. After one stick stage, there is two stick stage, and then there is crawling stage where he cannot walk. So these were the two questions from food poisoning. That means we should go through it. We have discussed it in that session that khesari saag causes it. There is spasticity and boa poison is there. We have discussed this thing in our session also. Next question, they had given that there is a population who eat polished rice and there is pitting edema and dyspnea. So polished rice means they are talking about thiamine deficiency, and they are giving you the symptoms of wet beriberi with CHF, dyspnea and pitting edema. So thiamine with transcriptolase activity is the reason which is causing this problem. There is deficiency of thiamine and it has this transcriptolase activity which you might have read in biochem. Chalo, this one question was they had given this picture of a child with no hair. I was trying to search for such picture, but in this picture also there is some hair. In the real exam picture, there was no hair over here. And they asked, they have history of raw egg white consumption, which vitamin is deficiency. There is biotin deficiency because avidin protein of raw egg, avidin binds with biotin and it decreases the absorption of biotin from the body, which lead to hair loss. So that's why we should eat the full egg, not just egg white. Okay. Now, next question. There is a child with history of late wound healing, repeated infection and dryness around mouth and eye. So it is zinc deficiency, and the symptoms here is suggested of acrodermatitis enteropathica. So because of enteropathica, they will not be able to absorb other thing also. There will be diarrhea and all, and that will cause delayed wound healing and repeated infection. Anyway, zinc deficiency lead to these things. Plus, zinc deficiency also lead to preterm delivery also in some mothers. Okay, so that is typical symptom of zinc deficiency. Along with zinc deficiency, there was one question with knee of the child with typical this feature of bow leg, with vitamin D deficiency. And so that was also being asked. Okay, and as I hope you all know, in vitamin D deficiency, there is ping pong skull, delayed eruption of teeth, rachitic rosary, all the joints will be more prominent. There will be barrel shaped chest and metaphyseal widening. These all symptoms you will find along with this bowing of leg. Then there was this simple question, bleeding gum with delayed wound healing in scurvy. What is the reason? Of course, decreased collagen synthesis is the reason for that. Then they presented this question that a child is having fever, malaise and paroxysmal bout of inspiratory cough. So what is the antibiotic which you prefer? The antibiotic which we prefer in adult is erythromycin. And the confusion was between clarithromycin and azithromycin. So again, we have to go to Park to see it. Park has written that although several antibiotic, you can see it, although several antibiotic are effective, but erythromycin is probably the drug of choice. But possible alternative are azithromycin and clarithromycin. So that means Park is again saying that if erythro is not given, clarithro can be correct. Now, which one is better, azithro or clarithro? So they have cleared it further that infant and young children should be kept away from the case, and in children with whooping cough, what antibiotic which we give? Erythro or azithro. Okay. Plus the pediatric MAM faculty of Allen has also clarified it through Nelson book of pediatrics that azithromycin is the preferred antibiotic for pertussis in children. So the answer was definitely azithromycin according to Park and Nelson both, not clarithro. And erythromycin can also be the answer if given in option. But in children, azithro is preferred. In adult, erythromycin is the drug of choice. Okay. Chalo. The next question was that they have asked this question, most sensitive indicator of availability, utilization and effectiveness of healthcare. Answer is IMR, infant mortality rate, for sure. Infant mortality rate is best indicator of three things. One is it is the best indicator of health system of the country. Second is it is the best indicator of impact of ASA work. Whether ASA is working or not, it can be proven by decrease in IMR. If IMR decrease, ASA is working. Third thing is also tell about condition of female in that country. Why? Because if female is malnourished, then there will be preterm delivery before 37-week period of gestation. And preterm delivery is the most common cause of IMR. So if IMR is low, it means female condition is good in the country. So that is why we use IMR in physical quality of life index also, PQLI also, to measure the socio-economic growth of the country. Now let's look at the other option, child death rate and under 5 proportional mortality rate. So see, in Park it is clearly written that infant mortality rate is the most, it is direct line question from Park, says sensitive indicator of utilization effectiveness of healthcare, particularly perinatal care. Then child death rate. Child death rate means those children who are dying after 1 year, between 1 to 4 years. So child death rate do not include premature preterm delivery and asphyxia as the cause. Child death rate, most common cause is pneumonia, then sepsis, then diarrhea, then malnutrition. They are the reason of child death rate. So child death rate, they have said that it tells about inadequate maternal child health services. It tells about insufficient nutrition, low coverage of immunization and adverse environmental exposure. And IMR is something which can be 10 times more in least developed country, but child death rate can be 25 times higher. So if they ask about best indicator of immunization services, best indicator of nutrition services, then we will answer child death rate. Now what is under 5 proportional mortality rate tell us? It tell us, it reflect both infant and child mortality rate, because under 5 means from birth to 5 years how many die. So infant and child both are included in it. But because it is clearly written that IMR is the most effective sensitive indicator, so that is the answer of choice, definitely IMR. Maternal mortality rate is something which do not tell so much about the health system of the country. It only tell more about the female condition, although it reflect the health system, but IMR is better indicator than MMR always. Okay, chalo. Now, they simply ask this question. There is a case of diarrhea, dermatitis, dementia. That means there was niacin deficiency, pellagra, and that was a simple question. So there was a lot of question on vitamins in this time, which was there. Now, this was again one of the confusing question of PSM, and I have seen that the explanation is poorly understood by many of the students and even teachers. They had given a typical feature of boy hostel, and they said that they developed rash on their trunk. So it was the typical dewdrops on rose petal appearance, which is for chickenpox. Second, it was on trunk, so it is centripetal, again correct for chickenpox. Third characteristic, that it is pleomorphic, so it was different stage pleomorphic. And because it is centripetal, it do not occur on palm and sole. So that is the case of quite sure chickenpox. Now the point is, which management is correct, they ask. So before deciding the management, let's see what Park is telling about it. See, first thing that Park is said, that there should be isolation of case for about 6 days. Let me enlarge it up more. Isolation of case for about 6 days, not 14 days. 14 day to 16 day is the average incubation period, and incubation period is for quarantine, not for isolation. Isolation depend on infectivity period. For chickenpox, it is 2 days before rash, 4 to 5 days after rash. So it is clearly written in the guideline that isolation should be of 6 days, not of 14 days. Second option, second point, the varicella zoster immunoglobulin which we give, it should be given within 72 hours of exposure, not 48 hours. But there was one catch, that chickenpox is occurring in boys hostel. That means they all are adult boys. They had given this picture also, that adult male boy students hostel and is there, and they are developing it. So what will you do? So you can see this. What is the role of varicella zoster immunoglobulin? It is given to contacts to prevent severe infection in them. But severe infection of chickenpox occur in immunocompromised people. Pregnant female should be given first priority of varicella zoster immunoglobulin. Otherwise, congenital anomaly can occur. So pregnant female first priority, immunocompromised patient, old age, children. There is no role of immunoglobulin in adult, because we don't want to protect adult. Even if they develop chickenpox, it will be not with serious manifestations. So it is written in Park that the varicella zoster includes susceptible person, immunosuppressive, person with cellular immunodeficiency, person with HIV, exposed person, in particular part pregnant woman. Okay, susceptible and exposed both should be there. It's not only exposed. Then newborn should get it, premature infant should get it. It has no therapeutic value in established disease, and we do not give it in adult. So there was no role of giving varicella zoster immunoglobulin to the boys hostels who are adult. So one more thing that could have been included in the option, that varicella vaccine can be given. It is recommended for post-exposure administration to unvaccinated healthy people with age more than 12 months. So vaccine is something which should be administered as soon as within 5 days after exposure. But there was no option with vaccines. They were only asking about varicella zoster immunoglobulin and isolation period. So isolation is for 6 days. This is correct. For sure 6 days is correct. And varicella zoster immunoglobulin is given within 72 hours. And this was the boy hostel, adult hostel. So there was no role of giving varicella zoster immunoglobulin. And 14 days is wrong for isolation. It is correct for quarantine. So this controversial question answer was isolate for 6 days only. Okay, no role of varicella zoster immunoglobulin here. Chalo, next question. This was the question, only one question from biostat, although it was in pharma also. They can discuss it also there. They said that digoxin is given and the dose become 4 nanogram, high dose is started and it reached too high. Now, half-life of digoxin is 40 minutes and we want to make digoxin reach 200. So, if you want to make it reach 200, how many minute time it will take? So, in the first half-life of 40 minutes, it will become 400 to 200. In the next half-life of 40 minutes, it will become 200 to 100. So, total time which is needed is 80 minutes. There was no calculation involved and it was simple. This time there was no question from biostat actually. Then they asked a question, simple question, child with cough cold coryza, there was coplic spot on buccal mucosa. So, what the child is suffering from? Remember, the coplic spot occur on lower first and second molar. Because upper molar is for parotid gland duct, extension duct. And the extension duct will not travel all this distance, will come and open here. So, extension duct open near upper second molar and coplic spot near lower second molar. This was a clear-cut case of measles. If it is rubella, there will be pink dot on soft palate called Forchheimer spot. This coplic spot and Forchheimer spot both are pathognomic. That means if they are found, there is no confusion in diagnosis. But how will you differentiate chickenpox, rubella, face images from measles? Chickenpox, rubella, they are always with dry fever. There is no secretion, cough, cold, coryza. Coryza means running nose. So, there is no secretion in chickenpox, rubella, which only occur in measles. Erythema infectiosum will have this slap cheek appearance and geographical map like rash. So, slap cheek appearance and geographical map rash, if you found, that will be erythema infectiosum. Okay, parvovirus infections. So, these were the questions. Along with that, there was also a question of varicella, where they have typically given all the congenital rubella syndrome symptom. They have written it that there was patent ductus arteriosus also, there was sensory neural defect also, sensory neural hearing loss also, and then there was the congenital cataract also. So, what was the disease? Of course, it was rubella. Other than that, there was a question on syphilis also. The clinical symptom were given that a female had a ulcer in genital area. The ulcer are not painful and there were non-tender lymph node swelling also in the inguinal areas. So, they had asked the question on syphilis. Then there was a question on gonorrhea also. They said a female with history of multiple sexual partner is having a discharge, a scanty discharge, and along with the discharge there is burning in urination. So, what is, and then they give some reagent which we use for diagnosis also, that was gonorrhea. So, there was question on chickenpox, measles, rubella, syphilis, gonorrhea, herpes simplex virus also, HIV cases, complications, and like molluscum contagiosum, histoplasmosis, that has been asked. So, infectious disease and vitamin deficiency was the main areas of question in this exam, and I really hope that you have done well there. But no matter how you have done in the NEET exam, one sincere request which I have from all of you is that continue your preparation till May exam. AIMS form is not yet out. So, please prepare for May AIMS, INICT also. Even if your exam have went very well, give that also, because in May AIMS 30 to 40% question are directly repeated. So, if you have command over 10 year of AIMS previous year paper and 5 year of NEET paper from 2018 onward, then you can get a lot of questions correct directly in May AIMS. And people with less preparation like me also get selected in May AIMS. And I got some 825 rank during 2012 May AIMS. And it is easier as compared to November AIMS. Many students are confused. So, if you continue for 2 months, then you might get a very good rank there. And no matter what is the result or will be there, just you have taken 1-2 day rest. Now focus for your journey ahead. And remember, if you are growing daily, then no result, no exam is tough. If we are growing daily, We should not be worried about any exam or anything in our life. We should just focus on that day and try to grow there. Okay. I hope all the best to all of you for your future. Enjoy the journey. Hasta la vista. Das vidania. Thank you so much. Bye-bye.